All right, welcome everyone to the 2021 CHILD-BRIGHT Virtual Symposium. First and foremost, I would like to acknowledge that on my end of this event here in BC, we're located on the Musqueam, Squamish, and Tsleil-Waututh First Nations territory. We are honored and grateful to be able to learn and share in this space. On that note, we are really excited to have you here today for the second iteration of this event that really was born out of our response to the pandemic. My goodness, more than a year ago already. Our session today will be divided into two main parts, and you are here for the first, which is the project videos and Q&A sessions. Once this session concludes, I guess at the end of the 90 minutes, we will direct you to our main platform so you can browse through the wonderful poster presentations that will take place for the remainder of the event. However, before we get things kicked off, there were just a few quick housekeeping items that I was hoping to go through so we can be oriented and know where we're supposed to go throughout the day. First off is just a few comments about using Zoom today. So we just ask that unless we are participating in the Q&A session, that you just be sure to unmute your microphone so we can cut down on any sort of background noise that we might have. And secondly, just to sort of limit some of the bandwidth usage and ensure that the session runs a bit smoother, we ask that you disable your webcam as well. And of course, during the Q&A session, as we call on you or as you speak up, you can certainly toggle those on and we can go from there. Now, in terms of the Q&A session, we'll get into some more details on that in a second, but for you to relay any of your input, we really have two options for you. One is just to relay your thoughts through the chat box. So you can just type in your question, make sure you address it to everyone, and then we can certainly relay it to the project representatives and then have them comment. The other option, of course, would involve you unmuting yourself and relaying your question through audio. And to do that, we just ask that you sort of raise your hand, so you can toggle that on by navigating to the participant icon again, and then just selecting the icon. And then we can call on you and work through those queries sequentially. And yeah, hopefully we'll get through all of them in designated time. So as you may have noticed with how we have the session set up today, it really is organized into two segments. As we mentioned, you're here for the Q&A and updates portion of it. And that's going to run for the next 90 minutes or so. We have organized these updates according to the three main CHILD-BRIGHT themes. So they're organized by CHILD-BRIGHT Beginnings, CHILD-BRIGHT Supports, and Bright Futures. We will play through all the updates from the projects relevant to each theme sequentially. Then we'll pause for a Q&A period, which will be about 20 minutes. And then once we wrap that theme up, we'll move to the next and keep the ball rolling. And as I mentioned at the top of the session, the second part of today revolves around the individual poster presentations and brainstorming sessions that are featuring novel ideas in the area of pediatric neurodisability research. And we'll toggle, or I guess we'll navigate to the platform in a second. But if you have had a chance to take a look at the plan for the day, the posters are currently organized into sort of 5 thematic areas. And you as an attendee are able to interact with the presenters directly through visiting their Zoom rooms at the designated time slots that they are scheduled to present. So now we have a chance to look at the schedule. I'm just going to switch over to the page to give you a sense of how to navigate it. So if you haven't had a chance to take a look at it yet. So if you bring up the page, you'll see it displaying on your screen right now. You're able to select or filter potential presentations that are of interest to you, either by searching through the displayed keywords or toggling the various themes that we have present here. And you can certainly just look at the selection of posters that are present there. Now, to attend any poster presentation specifically, you can just navigate to their entry that's on the platform, read through their abstract. You're able to download and view the poster that will be presented. And of course, I have a slow internet connection today, apparently. Yeah, so you can see, you can review their full poster, and then at their designated time slot, you'll be able to connect with them directly through clicking on the chat with presenter feature for that specific presentation. So that would be great. And I guess one thing, just to hopefully make it a bit more fun to help with the poster adjudication process, we ask that any attendees who are viewing some of these sessions, if you liked any of them in particular, we have a feature where you can vote for the ones you like, and you can just sort of toggle the star button to the top right of each title if a presentation was great and you really enjoyed the content. All right. So with that said, we'll switch over to watching the recorded session. So as I mentioned, we'll do them by theme, and we'll start with theme 1, which has half a dozen videos uploaded. So we'll play through them. If you have any issues, we'll certainly have the recordings available after the fact. So if there are any sort of streaming quality concerns or issues on that end, we will have them available after the session for you to review at your leisure. So it's gonna be one moment and I will switch over. All right, so you should, we did switch over to the compiled video. So we're gonna hit play and go for it.
Welcome patients, families, researchers, health professionals, and decision makers to our CHILD-BRIGHT project update on the maternal hyperoxygenation in congenital heart disease, or MATCH study. In 2017, we began the MATCH study to ask whether supplemental oxygen during pregnancy will improve brain development in fetuses with complex congenital heart disease. This is because brain development is impaired during prenatal life, which may be due to abnormal flow patterns and reduced oxygenation to the developing brain. For this reason, our study involves 2 objectives. First, to quantify the impact of a short 5-minute duration of maternal hyperoxygenation on brain oxygenation in fetuses with different forms of complex congenital heart disease. And second, to investigate the effects of long-term maternal hyperoxygenation on neurodevelopment in fetuses with single ventricles, by providing mothers with supplemental oxygen throughout their 3rd trimester of pregnancy. Our ultimate goal is to improve neurodevelopment during pregnancy so our newborns will have the best possible foundation to build upon as they grow older. Our team has made great progress, where so far we have recruited 49 of 150 mothers for our short-term hyperoxygenation study, and data analysis is underway. For our long-term hyperoxygenation study, we have recruited 15 of 30 mothers to assess the safety and feasibility of our intervention. So far, we found no harmful effects to the baby or mother attributed to the oxygen. However, we did find that our babies were slightly smaller at birth, but without clinical concern. On the bright side, our newborns had less brain injury before their first cardiac operation compared to those who did not receive supplemental oxygen, suggesting that there might be a potential neuroprotective effect from our intervention. Nonetheless, we're working closely with our Data and Safety Monitoring Board for detailed monitoring of the safety of this trial. As part of the CHILD-BRIGHT network, we actively keep in touch with our mothers and families. Through weekly phone calls to our mothers during their intervention, discussions during hospital visits, and our very first virtual meeting with our families and principal investigators last summer, we shared our experiences with each other to address strengths and weaknesses of our study. For example, our mothers and families expressed their gratitude for the active support and flexibility from our healthcare team. On the other hand, participant engagement has led us to improving the intervention, such as by humidifying the supplemental oxygen to resolve dry noses. Our mothers and families have showed great resiliency, courage, and strength, and we can't wait to have more discussions with our patient partners and key stakeholders along our journey to put patients first. Although this is a brief update, we gladly invite you to attend our poster session for more details and discussion. Thank you very much for listening, and we hope to see you soon.
I'm Rebecca Pierce, the mother of a now 11-year-old daughter who was born extremely preterm. I'm also part of the interdisciplinary team of the Parents' Voice Project. From a parental perspective, this project is incredibly beneficial. Outcomes of extremely preterm birth reflect what researchers have decided are important and are not necessarily what parents consider to be meaningful. Clinicians see preterm children infrequently and use standardized assessments to determine outcomes. However, parents live with their children every day. This means that they have a deeper, more relevant understanding of their children, their strengths and weaknesses, and their daily functionality. It's about time that parents' perspectives and voices are finally included in this research.
Hello, I am Ann Sinnott, lead investigator on the Parent EPIC study. And on behalf of my co-investigators, parents, and our participating networks, we're happy to give you an update today. Our study has 3 aims: to define outcomes that are meaningful to parents, to implement Parent EPIC to improve cognitive and language abilities, and then evaluate the outcomes. In aim 1, parents told us that they do not classify their children's level of impairment in the same way as healthcare professionals do. In another survey, they told us that we need to provide a more balanced view of the strengths and not just the deficits of children born preterm. In a survey using clinical vignettes, we learned from our parent respondents that cerebral palsy, developmental delays, hearing loss, and blindness are not equivalent, and that there are other health outcomes that are also important for us to report on. Delayed language occurs in about a third of babies born very preterm, and so we want to try to improve language. We have been doing this at 11 sites using a technique called EPIC, which is a proven method. It uses evidence, local teams, and known quality improvement techniques. One site partnered with the public library to be able to give out books and incorporate that into the healthcare visit to improve language. In our last aim, over the last 3 years, we have created annual reports that are available online, and we have seen that in some areas there is no improvement over time, but we have seen hopeful trends when it comes to falling rates of cerebral palsy, hearing loss, and visual impairment. We look forward to taking any of your questions. Thank you.
Research has shown that metformin can activate the brain's stem cells. In children with cerebral palsy, metformin has the potential to improve movement and cognitive skills such as memory. We're conducting a feasibility randomized controlled trial in children with cerebral palsy. Is the study feasible? Can we recruit children with cerebral palsy, and can they tolerate the metformin? What can the metformin improve? Movement skills, the memory. We also want to study the structure of the brain and see if we can see a signal when we do a detailed brain image. So we're really pleased to be moving this feasibility metformin study forward.
Quite simply, it has the potential to improve the quality of life for future generations. We need to know as much as we can about different interventions and the experiences of people with disabilities, or people with CP more specifically, to find ways to better help them. And it's possible that the metformin medication and the study could be one of those interventions. So why not try?
Essentially, there's just a lot of hope put on this. I know parents are extremely, extremely interested and engaged with this particular study because of what it may potentially do for their children, and for children who are, coming up to this journey that aren't quite there yet.
What does our study mean to you?
We want kids to be set in the best position possible to move forward, whether it be how they feel physically, whether it has to do with pain management, whether it's the ability to partake in various activities, both as kids and, later as productive members of society, whatever that means for them. It's just about setting us all up for, to make the most out of our lives, and be happy doing it. So that's what it means to me.
It's wonderful as a parent to know that someone is listening, someone is actively trying some new treatments and some new interventions for people living with cerebral palsy. We haven't seen that. I haven't seen that a lot in the last 13 years. I've seen a lot of studies that have been done from a therapeutic intervention perspective or some other interventions, but from an actual drug or medication that we may be able to give to people with cerebral palsy to heal their brain or to increase functionality in some way. I just think that that is extraordinary.
What is the hope that this study provides?
I'm cautiously optimistic. I almost don't want to talk about it. You can see by my previous answers that I've been a bit guarded of saying that kind of thing, but I'm not along when Brenda sort of alludes to it. It's a sort of hope that we've never seen before, and I almost don't know if I want to believe it now, respectfully, to everyone. And, even as someone who's older, I don't necessarily know that it will be something that can help me or help my peers, but to help future or current generations that are younger generations, that hope and that potential is invaluable.
I believe the options are limitless. I mean, this is just the beginning of this study, and who knows where it goes from here. And eventually I hope that it becomes a piece where we can just go to our doctor and ask for a prescription for metformin, and that will just be something that we'll be able to give to our children. And it will just be a commonplace treatment, as we see with other medications that we give to people with cerebral palsy for other things that they may be living with. So that's my hope for it.
Many children with perinatal stroke are left with weakness and motor difficulties on one side of their body, called hemiplegic cerebral palsy. The effects of this on hand and arm function often cause the most difficulty. Current rehabilitational treatments or therapy are important but are often incomplete in their ability to restore this function, leaving a great need to develop new strategies for improving motor function after perinatal stroke. We have recently learned important lessons about how the brain repairs itself following a stroke. Studying this plasticity will help us understand perinatal stroke better while developing new ways to treat the weakness that results. The SPORT trial is a large, multi-center, randomized control trial running in Calgary, Edmonton, and Toronto. We have currently had over 60 children participate across the country. The purpose of this study is to see if a new treatment called transcranial direct current stimulation, or TDCS for short, can enhance therapy to improve motor function in children with perinatal stroke. So far, the camp has been going very well, with no complications and great participation. Stay tuned for the results from this trial coming in the next couple of years.
Hi there, my name is Serene Kirpin. I'm a principal investigator along with Drs. Jennifer Walker and Astrid Gutman on our project, our CHILD-BRIGHT project titled Prenatal Opioid Exposure and Neonatal Abstinence Syndrome, a research project with Indigenous peoples in Ontario First Nations. So our project has two arms, both a qualitative and a quantitative component that involves 13 First Nation communities. To give a bit of a project update, we are in the process of reviewing and vetting our qualitative findings with internal members of our Indigenous team and participants, and then also community stakeholders from each community. For the quantitative arm of the project, we're in the process of analyzing and interpreting data requested by the community. So, for example, prevalence of prenatal opioid exposure, or perhaps other maternal or infant characteristics seen as important to that community. This data has been gathered through ICES with particular support from the Indigenous portfolio. We're currently in the process of developing our first sets of reports for communities, and these include a braided report that brings together the qualitative and quantitative findings, and also technical reports with more detailed data. Moving forward, we are really excited to be returning these findings to communities. What we are seeing as we start to bring together the qualitative and the quantitative finding is rich and comprehensive information that provides a much more complete picture of prenatal opioid exposure in Indigenous communities. One benefit that we're seeing, so for an example, is that if we have one set of data that might be reporting difficult or perhaps negative outcomes, we couple that with community developed strategies to address those challenges, and also stories of resiliency and family strength where we've seen children and families impacted by prenatal opioid exposure or neonatal abstinence syndrome have really healthy and positive outcomes. Our community partners are excited to receive the findings, and what we are hearing from them is that they're going to be using them to advocate for better supports and strategies for their families in their communities. They're also keen to get a better understanding of the perspectives of their community members. So this could be beliefs about opioid misuse during pregnancy, community beliefs about the infant and child outcomes, and community specific and really important culturally relevant strategies to prevent prenatal opioid exposure and help children and families. We are still in the early days of returning findings to our community partners, but we're excited about the potential for future collaborations as our community partners decide what steps they would like to take with their data. Thank you.
All right, welcome back, everyone. Thank you for our Theme 1 investigators, for our Theme 1 teams, for updating us on some of the great work that they have been doing. So this leads us to the Q&A period. So with that, we're going to call on all of the audience members here to share some of your questions that you might have for these projects specifically, or even big picture, pie in the sky type of questions. I do ask that for all the project representatives that are here to field these questions, I ask that you please toggle on your webcams. So we can have you all, we can distinguish who you are, and if we have to, we can direct questions appropriately. Well, I guess as we wait for you to think of any questions you might have, we do have one prompt that we are hoping to get some input on from all of the projects today. So I'll move to that. And then hopefully that can get some of the thinking starting, and hopefully it will inspire some questions from your end. So I'm generally directing this to any of our Theme 1 investigators, and you can feel free to chime in and mute yourself and address the prompt. So essentially what we're asking is, if the sky was the limit and your group had unlimited available resources, where would you take the research from your project next? What would the next steps look like for you?
So Pierre, it's Stephen. And well, linked to project 1.1, where my answer may not be totally relevant to that project. As I listened to some of the others like metformin and sport, I couldn't help but wonder about combination therapies as a next step if we were thinking sky's the limit. And I'd love to hear from those teams whether they see that in their future.
I think it's Darcy Failings. Hi, everybody. I really enjoyed hearing all the great videos. I think Adam Curtin may be on the line, and Adam, please feel free to weigh in, but Adam in the stimulation trial is already doing a combination therapeutics. So did you want to chat a little bit about that, Adam?
Sure. Hi, Darcy. Hi, everybody. Yeah, it's a good question, Steve. I think it's very tempting to think about combinations. The ability to test them is obviously the big challenge that, as we're all experiencing, it's really hard to test a single intervention in a trial. I think all three of us, at least probably more on the call, would agree. But the idea of synergy or at least additive effects, I think, is really exciting. And I think that could be a exciting next direction, especially if if one or more of our trials starts to show some signal and some positivity, how to amplify that. My other answer to the question that probably also applies, probably to Darcy and Dawn at least, is the idea that earlier is better, and which I think we all pretty much believe, but it's just hard to show. In the stimulation world where our trial sits, that's how I would answer. Our next big challenge would be, how do we move into earlier phases of development? Because for those who aren't familiar, our trial is only in school-age children. That's mostly a limit of the current technology and the safety evidence. And we do have some neat ideas, and some of my team have some really cool ideas about how to move this idea of modulation into the preschool age range. To me, that's kind of our next frontier if we seem like we're on the right track with this approach. So I would add that to the discussion, that moving into earlier intervention, I think that would be the next exciting big kind of trial from our point of view.
Don Mabbitt here, also on project 1.3 with Darcy. Just kind of add to the combination therapy question. In some ways, the current project 1.3 is already a combination therapy trial, because we're combining metformin with physiotherapy plus or minus placebo, physiotherapy plus or minus metformin or placebo. So, in some ways, we're already doing that with, what I would characterize as a activity-dependent neuroplasticity intervention, i.e., rehabilitation therapy. So it'll be interesting to see the results of our trial. As everyone knows, we've had challenges recruiting because of COVID, but I do think the mechanism of action of metformin is probably better for these synergy types of trials in terms of priming the brain for other activity, kind of based on some of the animal literature. So I think I'm quite interested in seeing how we actually prime the brain for physiotherapy as a start.
And I'd love to wade into the discussion and answer Pierre's huge question, if the sky was the limit, where would you want to go? And I'd say for cerebral palsy, and we alluded to this in the video, that we have very few new treatments, and I see a huge opportunity to build translational neuroscience networks where we really bridge and move translational work forward. So where clinician scientists are working with basic scientists. And I really feel that partnering is really important in the field of cerebral palsy. So if we look at metformin, a lot of the early work was done in the basic labs, and then it has come forward because there have been some clinician scientists that have been quite interested, Don being one of the leaders. And so bridging that gap between translational neuroscience, basic science, and clinical science in partnership with our community stakeholders, I think is really powerful.
Wonderful, everyone. Thank you for that wonderful considered input. We do have a few more questions that trickled in from the audience. Let me just, we can just pull those up in a second, and we will direct them if they're directable, and if not, I guess they can just be general queries that any of you may want to comment on. So one question we had was for the neonatal follow-up outcomes project. What outcomes did parents feel should be measured? And can you elaborate a bit more on this?
Hi, it's Ann Sinnes. Thank you for the question. And I think the exciting thing that the parents are telling us is information that we already know. So it has to do with what's the health of the children. Do they need to be re-hospitalized? How are they feeding? How are they sleeping? Are there behavior problems? And for those of us who are parents, we think back to those are aspects of day-to-day life as a parent. So moving forward, we are exciting that it will be easy for us to incorporate this information into our annual reports, into what we tell parents. And we didn't have enough time in the video to talk too much about our next steps, but we will be putting together a workshop to take all the different aspects from parents and creating recommendations which we will put into place for the Canadian Neonatal Follow-Up Network, and then be able to share with the world internationally so that parents are getting the information that more accurately reflects what children who are born very early, what their lives look like. Thank you.
Wonderful, thank you. We have one question from Katie Griffiths, and I guess this can go to all the projects. And what it's asking is, so what's the biggest challenge getting participants in your project, if even it was an issue for your study?
I can weigh in related to the metformin study. Certainly the pandemic has impacted our ability to recruit. It's a time-intensive commitment for families. We're providing active therapy 2 times a week over 16 weeks. And it represents numerous visits to the rehab center. And so that intersecting with the pandemic has certainly made a challenge. And then we have quite a list of eligibility criteria just to ensure as much safety as possible. Some families are quite interested, but then the child doesn't meet the eligibility criteria. Don, I don't know if you have any additional comments related to metformin.
No, you covered it.
Okay.
I can add for the sport trial, similar, our main challenge is just meeting criteria. We rightly or wrongly had to be fairly selective with a variety of inclusion, exclusion, and that's usually the only reason why families aren't able to participate. Those who meet the criteria, and we made them as open as possible, the recruitment rate's been very high. Not without challenges, and those challenges, by my experience, and Darcy recruits to the trial, she might have a comment. It's as you'd expect. I think it's family specific. Like each family has their own needs, their own challenges. Sometimes it's geography, sometimes it's other parenting responsibilities or challenges, or just plain old life, scheduling that gets in the way. Our interventions are also very intense, and it requires a large block of time. The pandemic, of course, has complicated all of those things. So I think we've learned a lot from the families about what the real life challenges are of participating in a trial like this. And we've done, I feel like we've done everything we can to try to accommodate those. We've made a lot of adjustments to our criteria and our process while trying to maintain the integrity of the trial. To accommodate families, but it is sometimes a challenge.
This is Ann Sinnis again. In our prematurity follow-up study, we didn't need to recruit for a trial, but we felt it was very important to make it as easy as possible for parents' voices to be heard. And we did that in several ways. The first was when we tried to incorporate it into clinic visits so that it was one simple question when they were at their visit, And in that way, we were able to get a very large number of participants. And then we recognized that for other aspects, we wanted to get more in-depth knowledge, and we wouldn't be able to get quite as many parents. But then how could we do it? Did they prefer doing it online? Did they prefer doing it by phone or by paper? So giving parents as many different options as possible to provide input. And then lastly, with the pandemic, we had to, it helped us become more creative. And one of our surveys that we call the clinical vignettes, we've been using a snowball method. So we've been using our parent partner websites and forums to get it out. And then with the snowball technique, the respondents are able to send it on to their friends, family, anybody else they think it might be interesting. And this has the ability to increase the number of responses you get in a very quick way compared to when we were trying to go individually from parents. So the pandemic has helped us think a bit more outside the box.
Wonderful thoughts. Yeah, it seems like we're going on full steam now. We some really great questions have come in. I think we'll ask one more of our theme 1 group here, and then we will switch over to theme 2 to the theme 2 videos, and then ask them some questions. And it's some of the ones that were submitted right now would be quite relevant, so we'll keep those and definitely circle back to them throughout the session. So one other big picture question to the group is, so if the sky really was the limit, have we given any thought on how we would give access to everyone?
I can maybe start for the match study, which our challenge in some respects has been that we weren't able to go to a multi-center study as we planned. And this was largely because of safety concerns about our intervention, I think. But I hope that if we are able to reassure people about the safety of the intervention, then we would certainly be able to go to a multi-center study and look perhaps to other centers in North America to quickly get a large number of patients, because our intervention is actually would be relatively easy to roll out to subjects. It's our intervention is oxygen, which is of course widely available and a cheap therapy. So we feel that that's going to be perhaps the least important hurdle, is being able to deliver the therapy once we've actually been able to show its efficacy.
Hi, it's Adam. I'll just add to Mike's comments about level of evidence that we would be in a similar way. We're doing a multi-center trial. That's pretty good for PEDS rehabilitation. But this is still, even if we get a nice positive result, this is not going to absolutely prove that the concept works. It will need validation and replication at the very least. It will need more than that to ever become an insured service. But this is, I think, an important step. And we have tried to keep an eye on making it scalable and practical. We're talking about brain stimulation, but it's actually very inexpensive and quite easy to learn, and therapists, parents even can do it, can learn how to do it. You need a bunch of therapy, that's expensive, but parents are great therapists, and we've had therapy students involved in the trial trying to keep costs down. So we are thinking about those long-term sort of scalability issues. We can't let things get too far ahead of the evidence that before we try to scale it up, we have to be sure it actually works. So I hope the next steps will be clear if we can acquire the amount of evidence we're aiming for with this trial.
And I would just say what Adam said for the metformin trial. Exact same answer I would think Darcy and I would have.
Absolutely, and I was just going to add a little comment on a really interesting area of research happening within providing therapy. And I think the pandemic has really stimulated an interest in, can we provide virtual therapy effectively? And that if we can certainly make things accessible. So within our metformin study, I mentioned that the frequency of visits is quite significant. So we have transitioned to some of our therapy virtually. But there's a whole area of rehabilitation science looking at the effectiveness of interactive computer play as a therapeutic option to provide therapy, including some of the therapy that we provide in Adam's study for constraint therapies. So it'll be great to see where that evolves. And certainly that would help people who are living in rural locations.
Wonderful. So I think we're going to have to end it there and move on to theme 2. Thank you for the great thoughts and insights you had all shared. And I hope you guys can stay on, and hopefully we can keep that conversation going throughout the remaining 2 themes of CHILD-BRIGHT's project updates. All right, so hang out with me for a moment. I'm going to switch over. We'll do, I believe we only have 2 videos in the next session, so we'll be back shortly to the Q&A period. And so let me go back to our videos, and then we will get going.
Hi, thank you for attending this update for CHILD-BRIGHT 2, Project 2.2, Strongest Families Neurodevelopmental. My name is Dr. Patrick McGraw. I'm from Dalhousie University and the IWK Health Center, and I'm co-investigator with Lucy Locke at McGill University. Our project falls under the Theme 2, Bright Supports, which aims to integrate mental health supports into care. Since the beginning of this project, we've worked with an incredible parent advisory committee who helped us adapt the Strongest Families parenting program to meet the needs of neurodiverse children and their families. The program is called Parents Empowering Neurodiverse Kids, and it's designed to help parents with challenging behaviors such as problems with children's self-regulation, meltdowns, and transitioning to new or unexpected situations or getting along with others. We are conducting a very large study to see if the program is helpful for families. So far, 370 families have taken part in the study, and working very hard to reach our target of 450 families by the beginning of November. In addition to this ongoing study, we have developed and are testing a new program to help parents deal with trauma associated with their child's health and well-being. This project involves a one-on-one online program called Life Beyond Trauma. The project has its own parent advisory committee and is being presented in the poster session. We hope that you'll take some time to see that important presentation. We also have had a number of trainees taking part in our projects and are very pleased to have 3 poster presentations this year. Athena Milios' study will be looking at perceived benefit of online support group. Emma Vanderlee is reporting on a qualitative study exploring parent advisors' experience taking part in research, and Karen Turner will be presenting her upcoming study on the relationships between work and family factors, employment status, and parent well-being. As we approach the end of recruitment for the Strongest Families studies and reflect on the new projects that have emerged from our partnership with families and trainees, we are very proud of the work that has been accomplished. We join you in looking forward to the future as this year's theme suggests. Our plans for Strongest Families projects in the future are very clear. We first of all need to finish the projects, and then we'll publish them. And our real goal is to have these available to all Canadian families who need them. This will be accomplished through our partner organization, the Strongest Families Institute, and it will be paid for, we hope, by the provinces and health authorities across Canada. Thank you very much for your attention and have a great day.
I'm Jennifer Crosby. I'm the principal investigator on Mega Team Project 2.5 of the CHILD-BRIGHT Network. Mega Team is a video game-based intervention targeting executive functions in children with neurodevelopmental disorders or other brain-based disorders. The objective of the clinical trial is to use a novel video game-based intervention to improve executive functions to possibly or hopefully have a downstream benefit on self-regulation, attention, and concentration. The current trial includes children who have attention deficit hyperactivity disorder, autism spectrum disorder, and congenital heart disease. Thus far in the trial, we are over halfway through with particularly great recruitment in our largest study group, which is those with attention deficit hyperactivity disorder. As it is a clinical trial right now, while we're trying to get that data in, we're really focused on recruitment and getting through the participants that we need so we can really understand what's going on with the trial. Of course, 2020 and 2021 has thrown us some curveballs. And the inevitable pause in research that happened with the pandemic and some subsequent pauses after that. We're conducting the study at sick kids. And so even when we opened up the clinical trial after an initial shutdown back in March 2020, there was some hesitancy on the parts of families, which was understandable. So the team and I worked together and we enhanced our recruitment strategies, came up with some new materials, some new approaches via social media, and we were able to identify some novel avenues of recruitment. But again, as restrictions were put in place, we did have to at times scale back and then scale back up again. As vaccines are rolling out and weather is getting better and number is coming down, I'm optimistic that all the work we've done in the background around enhancing our recruitment materials are going to put us in a really good position to finish out the last half to 1/4 of the trial. Thinking about next steps, we're really excited about having a chance to look at the data. Working with our youth advisory and family advisory, when that data is available, we'll be looking to understand it, interpret it, come up with knowledge translation strategies, and ways that we can really understand and disseminate the information. Beyond that, we're also excited about what's going to come next. So implementing changes around gamification, modifications that will enhance gameplay, enjoyment, and motivation. These are things that may be independent of the actual data that we'll receive, but has really been important feedback from the individuals who've been playing the game. So as we think about the next year, we're really excited about finishing out our data recruitment, having a look at the data, understanding how this game is benefiting children with neurodevelopmental disorders and brain-based disorders, and also really thinking about next steps in the development and enhancement of this novel brain-based intervention.
All right, welcome back again, everyone. Thank you to Pat and Jennifer for their great updates. So again, we're going to open the podium up to everyone to ask their questions. We do have a few that the previous session, I guess the previous theme had inspired, so we'll get to those as well. And I guess to get things started, we'll pick your brains on that big picture question that we have, Pat and Jennifer. So again, if the sky was the limit and your group had unlimited resources, where would you take this research next?
Okay, I think I mentioned that. I think that the next step in the large-scale project, would be to bring it over to Strongest Families and then move it across the country so that it's available. I note that we were doing both studies as single-site studies, but we had participation from across Canada, and so that went very well. I think that if they're effective, all we need is the resources to do a second study with the PTSD of parents and then to move it into care.
All right. Maybe for me to answer that question. So I think for us, really, it would be diversifying and taking the game to other conditions that I think would benefit. There's a number of conditions that have executive function deficits that would benefit from this kind of intervention. So it would really be taking the results that we know, pushing it out to other conditions and disorders, and really improving the dissemination of it. So how can we give kids access to it? It is something that can be done at home. I think it has some real potential to be scalable up and to really give access across a range of children and youth, and perhaps really kind of expand it out to slightly older kids, make sure that we have content that's interesting both to younger kids and older kids as well. So really it's sort of taking what we've learned here and pushing it out farther to access a larger group of individuals.
Thank you, Jennifer and Pat. So we have some questions coming in. So I will just read them off, and yeah, feel free to chime in, and we'll keep the discussion going. So Jennifer, I guess that the first one is for you, and I'll just read the prompt directly. So for video game therapy, as a mom of a 4-year-old with suspected ADHD and a gamer, first off, amazing. Second, what's the outlook for this project in regards to getting it to the general public? And a side question, what's the outlook for getting therapy for younger patients?
So I'll tackle the first question. We really were trying to create a game that was not going to be too expensive and really could be accessible and didn't have some of the barriers that currently exist with these kinds of games. So ultimately, yes, we would like to make it accessible and available on regular platforms. So that is definitely on the horizon for us once we have a bit more information and we can make some recommendations around who it will be helpful and what kinds of the amount of gameplay and those sorts of things. So definitely that's one of our endpoint objectives. With regards to younger kids, that would also, when I was just talking about other populations, I think younger kids are definitely something that we would like to explore. Right now, we're looking at 6 and up, but definitely the games I think would be of interest to younger kids. And so our next phase of research will be exploring that, making sure that they can play it and what the benefit might be for them as well. So yes, both younger and older patients, I think, would be the populations we'd like to explore next. For the older, it's more about content, making sure things are interesting and that they sort of feel like the content's not too young. But for the younger kids, I actually think the game that we currently have would be usable, actually probably down to 4. So that'll be hopefully on the horizon as sort of a next point of exploration.
Wonderful, thank you, Jennifer. I do have a question for you, Pat, I believe for the Strongest Families project, and it's asking whether have you looked at or considered looking at PTSD of siblings?
We haven't. We mostly because we have not enough money and too many tasks to do with the 2 trials that we're running. But the logic of it and the whole approach would be very similar. The intervention that we're using for PTSD is it has been adapted by other groups in the world for kids, and so I don't see any barrier to that. We'd want to again to trial it. The thing that we did differently than what has been done before, by and large, is we did it first of all by distance. So everything is done by distance. There has been some of that done before, and we did a preliminary, we did a meta-analysis of that that's now been published. But the second thing is that we had all of the delivery is done by non-professionals, by paraprofessionals, highly trained, well monitored, and outstanding. Actually, the parents that we've had in our trial, some of them have extremely difficult situations that they've dealt with, and multiple situations, some of which were based in caring for their child, and some with previous unrelated events. So it could be everything from a traffic accidents to an assault or whatever. Because as you know, or most people would know, that PTSD is more common the more trauma that you have. So there's a dose relationship between trauma and PTSD. But certainly we would be very interested in working with kids. We have lots of experience working with kids in other areas, and that's something that we will very much consider. The biggest challenge is funding.
I guess I would add to what Pat's saying in that I think one of the, I know this is about parenting of neurodiverse kids, but these same principles apply in many respects to the school context. And these children also represent, as much as they're challenging to parents, they're also challenging to teachers and educational assistants. So I've wondered about the adaptation of this program for a school context.
And Penny Corkum has done some of that work, not with this population, but with teaching teachers how to help kids with ADHD. And that trial is completed, and I think she's beginning dissemination of it. So that's indeed, as Lucy says, a very, very important area. Because unfortunately, most teachers don't know what to do with kids with ADHD, or they only learn by experience rather than from their teacher training.
Well, and it's not just kids with ADHD, right? Ours is across the neurodevelopmental spectrum. So
yeah, and
she's behaviorally dysregulated with that are neurodiverse and are often represent. Teachers will say, take your kid home once you've got your behavior problems figured out. So
yes, but that's even true for uncomplicated ADHD oftentimes.
All right, so yeah, we have a great general question that I guess is applicable to both projects. So feel free, if anyone else has any additional queries to ask, feel free to put them in the chat box or raise your hand. But I guess I'll shoot off with this one that we have right now. So if shown the outcomes of the studies are positive, how feasible will it be to implement the interventions in Canada, knowing how diverse and big the country is? Wouldn't the access of remote communities to services be a problem to ensure that these best treatments or interventions are actually localized and delivered there?
So maybe I'll comment, and then I'm sure Pat and Lucy will. So our intervention's virtual, and there's a number of different ways that it can be accessible. It doesn't require a stable Wi-Fi connection for us, so people can, as long as they can get somewhere to download it, they can do it. So at least from a technological perspective, I think it does have the capacity to be, spanning the country. Of course, I think work always needs to be done around ensuring the information that's provided is sort of best suited to a range of different populations and communities. So I think some more work looking at that would be important. But ultimately, I think after undertaking some good kind of consultation and getting feedback from the different populations and groups that we would like to disseminate to, I think the technology itself is quite amenable to quite broad span distribution.
Similarly with us, we collaborate very closely with the Strongest Families Institute, who's actually providing the coaching for the neurodevelopmental project, and we're doing the coaching for the PTSD project in my own lab. But the Strongest Families is now across Canada, wherever governments will pay for it, and that's again is the rate limiting step, including the territories, and certainly it's important to be very cognizant of local variations and local cultures and traditions. I think the one area that haven't done a great job in is with multiple languages. So that's, especially with immigrants and with people who don't speak English or French. The plan is to have these trials available, these materials available in English and French. There's been inadequate funding to get the translations done at this point in time. So the trials have been run in English, but there's not a problem with the French language. And the Strongest Families Institute, who we, as I mentioned, collaborate closely with, it functions in both English and French.
Right, thank you, Pat.
Lucy, do you have anything to add?
No, I haven't. I guess, when we think about well, actually I do. When we think about the northern and rural communities, we also think, of course, about First Nations and their access. And I don't, although we did have someone from one of the communities in Manitoba working with us, I think again, it is probably something, if it was identified as a need by First Nations, that could be adapted, but that relationship is very much flipped, right? It needs to, the push for it or the pull for it needs to be identified, and so far has not.
All right, so we have some really, we still have some really great questions coming in, so we'll see if we can get to them. So the first one is directed to you, Jennifer, in terms of developing these the gamification of these treatments. So when making accessible the game in the future, have any viability and economic analysis been done on the cost of maintaining the software working in the future? So considering new operating systems, new device releases, and how these may impact any new requirements on the servers or any technical support that may be needed?
Yeah, that's an excellent question, and definitely an ongoing area for anyone who's working within technology. And I would say it can be a bit tricky based on the funding mechanisms that we often use. So we are constantly thinking about it and coming up with sustainable mechanisms to ensure that these updates happen, I think is important and needs to be built into any kind of plan that people are for disseminating and how that's going to work, because it changes all the time. Anyone here who's working with any of the technology-based remote interventions or work will know that it's a constant battle to make sure that the technology stays up to date and it works. And so we're constantly thinking about it. And I don't know if I necessarily have absolute answers beyond our current funding phase, but definitely it's important for anyone working in this realm to have that firmly in mind and to have the funding to keep it going in the back end. Yeah.
I might add something to this. I'm not sure that academic institutions, either teaching hospitals or universities, are the best place to have long-term sustainable carry-on of interventions that are developed. I think what we need other vehicles and either a private company or a not-for-profit company. We've gone for the not-for-profit model with the Strongest Families, and we now have over 100 employees and multi-million-dollar budget each year. But we have people that are devoted to doing that. We academics are devoted to something a little bit different. We want to discover, we want to show that something works, but we don't have necessarily have the skills to maintain something, to sustain it, to push it, to get it used in every corner of this vast country.
Yeah, I think that's a really great point that Pat makes, and one that's important to keep in mind as people think about the long-term sustainability. How do you keep that, and how do you keep it going long-term? Yeah.
So one last question for you, Pat and Lucy, and it's suggested by Janine, and it reads: what have you learned about the families in the neurodiverse community in regards to trauma when parenting?
Everything. The PTSD study did not originate with us, did not originate with the academics. It originated with the parents. They said to us, why don't you study this? It happened in a casual conversation that initially had, and with one of the parents when I was grumbling about some other work that I was doing on PTSD and didn't get funded. And they said, well, why aren't you helping us with that? But Lucy has had an awful lot to do with parents as well. And maybe she has other comments, but we've learned everything from them.
I couldn't agree more. But I think if I were to take the question literally, I want to speak to this notion of, the family as being different from parenting, which is different from parents. And the family, I actually have a doctoral student who's looking at family level outcomes of the intervention as a distinct entity in our first study on where we're helping parents to parent differently. I'm not sure that we integrated a family measure into the trauma study. Pat, do you remember a family level measure?
Well, no, we didn't. There aren't very good family level measures in a lot of ways either, I don't think, for this purpose.
Well, there's this parent report about their families, as there is a parent report about their parenting and parent report about themselves, et cetera, et cetera. So you're absolutely right. But still, what they're getting at is in what these family level measures are getting at are slightly different. They're describing, the cohesiveness of the family, the conflict resolution in the family, which are different than, what a parent is doing with their child, right? When they're parenting.
Right, exactly.
It's a really good question. And hopefully we'll know a little bit more about it over the next 2 to 3 years as my doctoral student finishes his dissertation.
Right, wonderful. So Lucy, Pat, and Jennifer, thank you so much for joining and taking the time to answer some of our questions. We'll head on over to theme 3 in a second, and then circle back to some more great questions that you all are raising. So bear with me for a moment. Hopefully the switchover is smoother this time, and then we will get things started again.
You or someone notices that your child might not be developing properly, so you're put on a wait list for 6 months, a year, maybe 2 years. All the while thinking, did I cause this? Am I a bad parent? What do I do now?
In the 3 years that I've been delivering the Bright coaching content to the research participants, I've seen a tremendous amount of benefit for our participants. For many, this is the first time they've had an opportunity to focus on what the experience of parenting a child with developmental concerns has been like, how their interactions with and understandings of our service system have gone so far, and to talk through some of the things that are holistic and foundational to how their children are doing, but are typically absent from other services.
I was thrilled to be able to contribute to the process of knowledge translation within the Bright coaching team. Together, we've produced 5 related publications. We've published our randomized clinical trial protocol, a commentary demystifying terms related to coaching, and a systematic review looking at all of the existing coaching interventions worldwide. In addition, we're currently in the midst of publishing a paper looking at our coaches' fidelity in delivering the Bright coaching program. Lastly, since patient-oriented research is a key element to the CHILD-BRIGHT network and is also at the basis of the Bright coaching program, we have published a manuscript in developmental medicine and child neurology describing a formal patient engagement evaluation process and our results from the perspective of our patient partners and researchers. We just received great news that this paper received the Editor's Pick Merit in the upcoming June 2021 issue, and we will be filming a podcast about our results for the official YouTube channel of Developmental Medicine and Child Neurology. So overall, it has been a very productive and enriching and one-of-a-kind training experience for me as a postdoctorate fellow within the CHILD-BRIGHT network and the Bright coaching program.
Let's imagine a world in which the time on the wait list isn't full of shame and guilt and worry. Instead, let's move those families from just surviving to thriving from the very first moment.
In Canada, when young people with disabilities turn 18, they are usually expected to make the change from getting pediatric services to looking after their own health in adult services. This healthcare transition is set by policy and happens whether the youth are ready or not. If the transition is not smooth, youth may experience negative effects such as missed appointments and medications. There may be burden on the family, such as parents having to take time off work, and more system costs, such as emergency department visits.
To work on a solution to the healthcare transition problem, we partnered with multiple stakeholders, including patients and families, to create an e-health tool or app to help youth get ready for healthcare transition. We have created an English and French version, as well as a support website. Using the app, youth take a step-by-step approach to developing knowledge and skills to help them start to take care of their own health. Our app is designed for a wide range of brain-based disabilities with common functional limitations and healthcare needs. We intentionally used this non-categorical approach of including more than one medical condition or disability to increase the generalizability of the app so that it will have the potential to impact and apply more broadly to Canadian youth with disabilities.
The trial includes two groups of youth between 15 and 70 years old to test if there are benefits to using the app compared to not using it. Recruitment began at first sight in September 2020, and within 6 months that site reached half of its target sample. We have screened 38 participants at an overall rate of 5 participants per month, or 14% of our target sample of 264. All Ontario sites were recruiting by November, Alberta by December, and the Maritimes by March 2021. Currently, 10 of 12 sites in 3 regions are actively recruiting, with the sites in Quebec to start in May 2021. Looking ahead at future goals, our team has recently submitted a CHR application for an RCT extension, proudly including 1 parent co-investigator, 2 parent and 6 young adult collaborators.
We are proud of this patient-oriented research program. From our experiences with our Patient and Family Advisory Council, we can share ways to help other research teams who are partnering with stakeholders in multi-year projects. Our partnerships have grown to be truly collaborative. Over the past 5 years, we co-developed and are now evaluating an app and co-created and are using materials to enhance recruitment and encourage youth and their families to participate in this trial. As a person who is navigating the healthcare system myself, I can tell you this app is fantastic to help people with disabilities take that next step towards greater independence.
And being a part of the PFAC has helped me understand how the research process works and has given me many opportunities to develop my skills as a patient partner.
All right, welcome back again, everyone. For this Q&A session, we have representatives from the Coach-Coordinated and Enhanced Neonatal Transitions Project, the Bright Coaching Project, as well as the Ready or Not a project that we just saw the recording of. So again, I'm going to open the Q&A period to you all. So if you have any questions, feel free to relay them. And to get things started, I guess we will go back to our big picture question and ask all of the project representatives who are here in attendance our big picture question. So again, if the sky was the limit and your group had unlimited resources, where would you take the research next?
Hi, everyone. I'm Tatiana. I guess I can start. I just want to congratulate everyone for the videos. They're really great. A lot of effort has been put into those videos. Thank you all so much. So for the Bright Coaching team, we have thought about this question, and we're thinking about implementation in the real world clinical practice. So how can it become a real service, a standardized service? We also would like to include new topics of interest. Telehealth and telerehab is very in right now because of the COVID-19 pandemic. And we're seeing a lot of parent participants who are bringing this topic up in the coaching sessions. So this will be something that we would like to include. So how to prepare for a telehealth visit with their child, and also to extend our coaches training to a wider population. One interesting approach is actually, can we train parents to become coaches? And by doing this, we might actually reach to the hard to reach populations and the vulnerable populations. That could be an interesting avenue in the field of coaching. So I don't know if other representatives from our team have anything to add.
That was great, Tatiana. If I can also add that, you know, a big challenge for us was accessibility. So if we, you know, the sky was the limit, how would we access those rural and First Nations populations that we haven't been able to access up until this point? So working with our regional partners is going to be really important when it comes to implementation. And hopefully those resources will be made available to us.
Any thoughts from CSENT already or not?
Camilo Gutter speaking. On behalf of the team, I see many of us joining as well. And I saw a question in the chat box actually about congenital heart defects. I was wondering if Adrienne wants to comment on that question, because you're involved in some exciting work.
Sure. I would say that this question here, our CHILD-BRIGHT, our Ready or Not transition group has really been thinking about this from the get-go. So I think that with the platform we created, we have a series of modules people go through it to prepare them for transition and transfer to adult care. And from the very beginning, I think we envisioned something a little bit narrower, and it expanded working with the PFAC. So I think that, you know, we have a platform, we could certainly add extra bits to it. So you know, the Megasonic, the game, for example, I think that there's more room for gamification. I think we saw this a strong knowledge translation piece and transferring to other medical conditions. So we've actually taken this platform created within this particular study, and we actually are creating a version for people with congenital heart disease. So we see this, what we've created, being able to transfer to other health conditions, and then certainly looking at scalability across the country. So we have always from the beginning thought, gosh, there's so much more we could do with this. So I think we definitely have a pie in the sky view of this project. So we see the options as limitless, but you're right, we need limitless resources also.
Which is always a challenge, I guess, too. Any other thoughts from members? We have a few other questions that came in, so we'll definitely circle through those shortly.
I can speak briefly for the CSENT study. So our study, if we had unlimited resources, I think the one question of interest for our team is, what would a more long-term support look like? So the support that we give to our families from the nurses in hospital only lasts up to the first 12 months post-discharge. And I think we've heard from a lot of families that a lot of the stresses often kick in after 12 months is over and parents are starting to go back to work. So if we had the resources to provide a longer term support, longer term follow-up assessment, I think that would be a really interesting next step for the project.
Great, thank you, Kayla. We have one question from Lucy. This is in relation to the transition programs. So there's a program at MAB McKay and at UMETS in Montreal, wondering if the projects have the bandwidth to investigate the possibility of recruiting from these programs as well.
Maybe I can start responding to that. Thank you, Lucy. That's a great suggestion. And I think also a very timely and helpful comment, because we are in the midst of rolling out our trial. As I said in the video, we have 10 out of 12 sites actively recruiting now, and Quebec is a region that is now starting up. We have ethics approval at both sites, and basically as we speak, the French app can be rolled out to the French-speaking participants. Having said that, we do want to scale up and speed up our recruitment rates. I must say that we do recruit through the treatment sites, but also in the participating regions, we welcome any participants through social media strategy to our trials. So if there are any potential participants at other sites, they can also participate in the trial. And Barb, I don't know, is our research coordinator on the trial. Is there anything you would like to add?
No, I think you covered that. And I'm making note too if there's a few more comments in the chat now about other suggestions. So we'll definitely follow up on those. Thanks.
Yeah, there's if you have any social media type information that you could send me, I can both share. I see Sharon's on the call as well. Hi, Sharon. I'm happy to take that up with the group that both Sharon and I are working with. That has to do with all about transition. So
thank you.
Thank you, and wonderful, because this is really where the network can sort of really show its strengths, right, by working together. So thank you so much. If I may ask or answer the question of the sky and is the limit, I would say two things. One is the CHR application that we are hoping to really follow these young people as they are leaving the pediatric healthcare setting into adulthood and see what the long-term impact is of using the app. And the other thing is that from the PFAC and our patients and parents, partners, we learned that we developed the app with those youth in mind that have the potential to take charge of their own health to some extent, also always, of course, with the help of their families. And we do realize that we still don't have a tool to support those who need more extensive help and also to support their families. So I think that's certainly something our project has discussed and is thinking about in terms of next steps.
So some great questions coming in. I'm just cognizant of the time, so maybe we'll do one general question to the group and hopefully wrap things up in about 2 or so minutes. So just in general, what has been some of the biggest challenges that you have experienced regarding involving the family or the patient perspective in your research? Has it been finding those partners, orienting them, or a host of other issues you may have experienced in doing research a bit differently in this way?
For our team, I wonder if Barb would like to comment on this. Sorry, Barb.
That's okay. Sorry, I was reading something else. Could you just repeat what you said, Pierre? Sorry about that.
No, I deleted the question. The question was essentially asking what were some of the larger challenges you have experienced, the project has experienced when it's come to involving the family or the patient perspective in the research process. Like, is it recruitment? Is it finding those partners? Is it orienting them to the work?
Yeah, I think I wouldn't say it's a challenge I guess, but more that's sort of where we found just that the need for extra time and resources and energy. And I think in our project, we're lucky that we have a pretty big team of research staff too, that we can sort of divide up our time. So my main role is around the coordination of the RCT. We have Sonia Strom, who's also on the call, who is sort of working to coordinate the qualitative and the patient engagement aspects. We have Alicia, who's our IT project manager, and we have a trainee, Linda, who's also very knowledgeable and involved in the POR aspects of our project. So I think I would suggest that that's what it takes probably to have enough resources and enough time to allot enough time in your timeline to really give it the what it needs to be able to do that. And definitely orienting partners is a very important piece. I think, like, being very clear from the beginning about what the expectations are and what like having those terms of reference and having those be dynamic, because we don't always know from the beginning what's going to happen and how that might change over time. But I think what we've heard from them in our check-ins with them over time is they appreciate us being sort of humble and acknowledging that we don't always know exactly what we're doing, but we're learning together, and we're open to feedback and to try and improve as much as we can, so that we're doing this together as we go.
And if I can chime in from the perspective of a trainee, I think one of the other things is that we're open to feedback. So with our individual check-in with PFAC members, what we learned is we've shifted towards having more subgroups. And with such a large team with facilitators and staff on the project, I think that's allowed us to also do other activities was not only related to the project, but also knowledge translation activities based on the interests and needs of PFAC members. So for example, recently we had more engagement from our young PFAC members about how they're interested in explaining about what research means to youth. And I think that aligns well with what's with our recruitment right now. So explaining what research means, and that's we created and worked together to develop the research video series. And that's just an example of one of our subgroups. Earlier on, we've also had a subgroup on recruitment and using social media strategies. So I think that's been helpful with moving towards that.
Thank you, Linda and Barb, for sharing. I realize we're right at the top of our time together today, so we have to fortunately have to end things there. But great questions, great discussion. Thank you so much for sharing your thoughts and perspectives. So I'm just again sharing the symposium platform site. We did put the link in the chat box again. So just as a reminder, if you were interested in following up with any of the posters and presenters that are going to be active in the next 2 or so hours, feel free to check it out that again and navigate to the poster that you're interested in and connecting with them at their designated slot. And again, if you like any of the presentations you do go to, please do give them a nice star rating, and we'll definitely work that in on our poster evaluation framework after the fact. So thank you so much for joining us today. We had a full house and it was really great and an engaged discussion. Hopefully do this again soon, and we will connect with you all again with some updates after the fact, sending you the link to this recording and looping you in with a few other tidbits as things move on. So have a wonderful day and enjoy the posters. Take care. Bye.